Antiarrhythmia. All right, so the conduction, this is our conduction. We know starts at SA node. That is our pacemaker. That's what should be pumping. That's what gives us to our 60 to 100. The next impulse is the AV node. It goes down through bundle of His, Purkinje fibers contract. Okay, so that is normal flow. There can be alterations in conduction. Medications that we are going to give are going to affect those alterations. Um, the for as far as heart block, I think we talked about this in patho. When there is something where that conduction is not happening, then our body can, if it can, pick it up at those other sites, which means that the heart rate will be lower based on where that that conduction's happening. Okay? That's all we're going to say about that. There are phases of action potential or automaticity, and it consists of depolarization and repolarization. Those things are controlled by sodium, potassium, magnesium, and calcium. Um, those specific phases are outlined here. I'm not going into this. We're not getting deep off in the woods of the different phases of that. The only thing that you need to understand is it is about to get a little bit confusing because we're going to talk about different classes of antiarrhythmics, and the classes are going to talk about, are going to affect different phases of this. Okay? That's really all that you need to know about that. It doesn't, that's it. Okay? If you care to know more, feel free, but the different classes are affecting different phases, which are affecting the action potential, which are affecting the conduction. The end. Okay. Um, so if our rhythm is abnormal, that is what an arrhythmia is. There's some abnormal rhythm. It can affect contractions, stroke volume, and cardiac output. So things that can contribute to arrhythmias are electrolyte imbalances, specifically those things that I said, the potassium, sodium, calcium, magnesium. Um, they can have, it can be due to an alteration in perfusion. It could be from structural damage. It could be from acidosis or an accumulation of waste. Like if somebody has kidney issues, that could potentially lead to arrhythmias. And then different medications can also cause arrhythmias. So as with everything else we're going to discuss, first of all, we want to know what the cause of the arrhythmia is because we would need to treat that. Okay? All right. So there can be changes in the rate, so tachycardia or bradycardia, where it's less than or greater than normal. Ectopic stimulation just means that the signal came from somewhere outside of the SA node. That could be due to premature atrial or ventricular contractions, or could be flutter or fibrillation, and those can be atrial or ventricular as well. There also can be an issue with conduction, so there could be heart blocks or bundle branch blocks. There could be issues with some other pathway leading to the conduction. I don't think I want to say anything else. Okay. So one factor in the development of cardiac arrhythmias is a decrease in oxygen delivered to cells or perfusion. That is true, correct. Very good. All right. I have the chart for the alterations across the lifespan is on page 796. For pediatric patients, it is very important. Doses have to be monitored, and that I'm going to say is true for every single drug that you give. The dosing is going to be closely titrated based on their weight and their age. Even over-the-counter medications, there's charts that say for what age or whatever. So we want to make sure that we monitor for adverse effects. Digoxin can be given to children if needed. Adenosine, propranolol, procainamide, and digoxin can treat SVT. And propranolol and digoxin are preferred for long-term treatment. If there is a serious ventricular arrhythmia or digitoxicity, lidocaine can be used. For adult patients, we want to monitor them closely. Geriatrics, they could have increased risk for side effects, may need decreased doses. And most of the drugs to treat arrhythmias are going to cross the placenta and breast milk, so we need to make sure the benefits outweigh the risk. Usually, beta blockers are going to be first-line treatment. All right. That is just the chart in the book. So these are the different classifications of the medications that can be given. I'm going to go over these more specifically, but the medications are affecting different levels of the action potential of conduction. Okay. So because they are affecting that automaticity or the conduction, and I'm treating an arrhythmia, meaning they are affecting the heart rhythm, what do you think is a side effect that could occur? If I'm causing an alteration in rhythm, if that is that, I want that to happen because it's not working the way that it's supposed to. So my desired outcome is an alteration in rhythm. What is something bad that could occur? An alteration in rhythm, right? So an arrhythmia is going to be a side effect of these medications. Usually, these medications are used in more emergent situations. Sometimes they can be used long term, just depending on what the patient has going on, or if it's affecting their quality of life. The I have a little note here that there's a table of the different classes on page 797 and 798, table 45.1. So the different drugs are avabradine, which is the hyperpolarization activated cyclic nucleotide gated channel inhibitors. Y'all knew that. The sodium channel blockers, the beta blockers, potassium channel blockers, and calcium channel blockers, which makes sense because I said sodium, potassium, calcium, magnesium, all those things can affect our conduction. So if I am affecting that, I'm going to affect the conduction itself. Okay. Here are the different classes. I'm not going to read this because I have slides for these, but this might be more condensed and might be easier for you to use to refer back to or not. Okay, so first we're going to talk about class 1. These are sodium channel blockers. There are groups within class 1. Okay, so class 1A includes quinidine, which affects atrial and ventricular dysrhythmias as well as supraventricular dysrhythmias. Class 1B is lidocaine, which is for acute ventricular dysrhythmias, and class 1C is flecainide, which treats the most serious life-threatening ventricular dysrhythmias. Also in class 1A is procainamide. And that's just a little something to help you break down, okay? So these block the sodium channel in the cell membrane during action potential, and then the further, that's for the class 1, the further breaking down is how they affect the action potential, whether they shorten that, prolong it, or affect conduction, okay? So this is just again, an overview of which medications fall into those categories. Now, on that slide before, I didn't have Renexa, but it is considered class 1D, and this medication can also treat angina. Okay, this is just another how it's affecting that. We're skipping. Another how it's affecting it, and we're skipping. Okay. So these are local anesthetics or things that are stabilizing the membrane and affecting that sodium channel um, and action potential. Okay. Usually, why we are giving medications in this class are ventricular arrhythmias. Okay. Most of the time, those are life-threatening. Can be for tachycardia and paroxysmal atrial arrhythmias in patients who don't have some sort of structural issue. Trying to see if there's anything. I don't think so. All this is just a repeat of what those medications are and the route in which those can be given. Okay. So contraindications for class 1, if they have an allergy, if they have some sort of hepatic or renal dysfunction, if they have a heart block or bradycardia and they don't have a pacemaker. If we give this to those patients, they are at risk for complete heart block. Heart failure, hypotension, and shock can be exacerbated because they can cause negative inotropic effects, which means it's decreasing the contractility. Um, and then if they have different electrolyte imbalances, it could cause other arrhythmias. So adverse effects, biggest adverse effect with the class 1 antiarrhythmics are arrhythmias. So we want to monitor closely when starting them. Other things can be fatigue, twitching, vision changes, tremors, may have nausea, vomiting. They may develop other arrhythmias, like I said. Hypotension, vasodilation, there is risk for cardiac arrest. So if I'm giving somebody something for an arrhythmia, what would I want to know before I give it? Their rhythm. I want to know that. How do I know that? An EKG or telemetry or just cardiac monitoring, right? So I'm monitoring their rhythm. Most of the time, especially if this is new, that is going to be continued, right? So they're going to be on continuous monitoring. I know what it was before we give this drug, especially if that is IV. I'm giving this drug and we're continuing to monitor the rhythm, okay? Um, there's risk for respiratory arrest, bone marrow depression, and then procanamide specifically has a black box warning for a positive ANA test, and then that can be with or without lupus. So it could be they develop something like a lupus-like syndrome where that's what it looks like. Okay, do y'all remember our telltale for lupus? The butterfly rash, very good. So they may also have pericarditis, swollen joints, or hepatomegaly. They're at risk for neutropenia, thrombocytopenia, hemolytic anemia, and liver failure. So if they can develop neutropenia, what am I monitoring? Neutrophils, white blood cell count, right? If their white blood cells count is low, what are they at risk for? Infection, okay? Thrombocytopenia, what am I monitoring? Platelets, what am I worried about? Bleeding, very good. Hemolytic anemia, same thing, basically, right? I'm monitoring red blood cells, hemoglobin and hematocrit, and then liver failure, we're monitoring their liver enzymes, right? If they develop liver failure, what are they going to look like? jaundice. They may have ascites. They may have pale stools. They might have itching. That would be an indication that that could be what's going on. Okay. Um, Anything that is going to also have a potential to cause arrhythmias are going to increase the risk of them developing arrhythmia while taking these medications. So digoxin and beta blockers, if they were to take those concurrently, quinidine, one of the medications in this class, can increase digoxin levels. So if they were taking that together, there's going to be an increased risk for digoxin toxicity. Okay. Cimetidine, which is a H2 blocker, given for like acid reflux, that can cause a risk for toxicity. And then these can increase the side effects of, or the desired effect of warfarin, which can increase the risk for bleeding. Okay. Um, and then grapefruit juice, it's back. Grapefruit juice or citrus juice, milk, vegetables can affect how quinidine is excreted, which increases the risk of it being the levels being increased. So one of the most important things, we talked about this with some other drug, which I can't remember what it is right this second, so sorry. But the most important thing with this, we don't want them to drink grapefruit juice. We want them to avoid that. But those other things, we just want to make sure that it is consistent. We're treating them based on whatever their diet is, so they don't need to change that because it could cause effects. Okay? Um, But that might be a question that you get, and then you can answer it because it's still it's enzymes. It's not specific to the juice or juicing process. Oh, I'm so sorry. I'm so sorry. The so our prototype here is lidocaine. And I have some other slides for this. One of the biggest things, this is used most often to treat ventricular arrhythmias. It acts very quickly, given IV. Very important for us to monitor their EKG while we're administering this, and then look for CNS toxicity like confusion or seizures. Mm-hmm. And one of the things, we haven't talked about MI yet, but one of the what people usually die from with MIs is deadly rhythms. So that would be why that is indicated. Okay. Um, So I do have this on another slide, but I can't remember if I wrote this, so I just want to tell y'all while we're here. If they were to develop lidocaine toxicity, if they get these at, adverse, I guess, side effects, if they present with that, we can give a lipid emulsion in order to combat that. Do y'all know about lipids yet? Have y'all learned that? So when people have nutrition deficits is most often when that's given, and they have to give them TPN. I think y'all talked about that a little bit, where they'll get PPN or TPN, where they're getting nutrition, electrolytes, glucose, fluid, all those things through an IV. Well, part of our diet, what we are also supposed to get is fats, and it literally is fats that you are giving through an IV, and it looks like milk. It is a white substance that's going through their veins. And so if somebody has lidocaine toxicity, they will give them the lipids to help them excrete that. Okay. Um, all right, so here is a picture of lidocaine toxicity, what that might look like. So seizures could be cardiac arrest, muscle twitching, um, altered mental status, and then difficult speech. Okay, and our little abbreviation there is SAMS. So slurred speech, altered CNS, muscle twitching, and seizures. So if they developed any of those things, if I said that someone had a ventricular arrhythmia and we gave them lidocaine, they just got however much lidocaine, and now the patient is confused, and I asked what we're going to do about that. What are we going to first do? Stop it. I'm not continuing to give it to them, right? So I'm first going to stop and then we'll give the antidote, right? And making sure we're assessing our patient, okay? So usually VFib, VTAC is time, when we're giving these, we're giving it IV, and then most of the time they're going to get a bolus and then have some sort of continuous infusion afterwards. So what else? When have y'all heard of lidocaine? Numbing, yes. So it is important to distinguish the indication, right? Because if I were to look at somebody's MAR and not be paying attention, and I just saw lidocaine, I'd be like, oh, they must have something that hurts, right? That could be the indication for that. They have lidocaine patches, they have in the roll-on stuff, they'll give you lidocaine like for nerve blocks. Um, there are other indications. So that this is a time where that really makes sense. And so I had somebody reach out to me the other day and said, I have a drug card for pain and inflammation. It wasn't lidocaine, but when I looked it up, everything about it looks very similar to the drug I did for cardiac. Is that all right? Like, is that a problem? And that is where indication is a big deal, right? Because maybe I have a lidocaine patch that I'm taking for back pain. You may have lidocaine injection that you are getting to insert an IV. She may be getting lidocaine because she has VFib. And all of those would be very important for me to know what the indication is, right? And the route. Because if you go give me lidocaine IV when my back hurt, what am I about to have? Which is going to look like Sam's. Yes, that's what it's going to look like. And what y'all going to do about it? We are stopping and giving me some lipids. Very good. That is the thought process there. But the route matters very much and the indication matters very much because those are when I first learned that was something that they gave in I'm like lidocaine. That is something they're giving in an emergency. And I could be wrong about this. You can feel free to correct me if I am, but I believe and I've even read this recently when I had bought lidocaine patches. That is a concern of if you are using it in that manner. If you're using it for a lidocaine patch and I'm like, well, my whole neck and back hurts. And so I just put 18 lidocaine patches on me. Now I'm at risk for toxicity, right? And the it will be different because that's going to be very slowly absorbed, right? But if I put them on at the same time and I just put an abundance of it, that could be an indication for that. Have you heard that? Do you know that? I think so. I think that that is the case. Regardless, it is something that seems benign of like, oh, lidocaine, yeah, we got that. And it is very serious. So just does it? Oh, yeah. Well, I don't think you're supposed to put it like on your chest. Yeah. But those things are like, who would know? Why would you think that? Why would you think that that's something that could happen from a lidocaine patch? It seems like why are they selling this at Walmart if that is that serious, you know? Um, but yeah, so there are the indications and the routes do make a difference. Okay, moving on. Class two. Um, so most of the ones that fall into class two, when you think of this, are beta blockers. Okay. What are beta blockers? They block the betas, that's right. And what does that make happen? right? So, what's not happening? It, what do the betas do? Do we know? It's sympathetic nervous system, right? That's what you're thinking of when you think of alpha beta in adrenergic, okay? Is sympathetic nervous system. So fight or flight. I am pumped up and I am ready. And what is supposed to happen is heart rate goes up, blood pressure goes up. I'm all excited. My heart's pumping harder, faster, right? To accommodate because I need to run away from a lion. So I need to go. If I'm blocking that, that's not happening, right? And so these are, I didn't get into the big PowerPoint on these. We have talked about it, but that is basically what's happening. And really, one of the most, what I think of with beta blockers is it's slowing the heart down enough so that it can pump effectively. That's really, it slows it down so that it can pump effectively. All right. It does affect the blood pressure, but not to the same degree. All right. Um, so these can be used for arrhythmias in addition to heart failure, in addition to what are we talking about? Arrhythmias. Um, so there are multiple uses for beta blockers. They haven't changed. They're still the same. The indication is just different here. Um, So they are reducing that sympathetic stimulation. Most of the time, what these are indicated for are supraventricular tachycardia, so SVT. There are other things that fall into this class, the common beta blockers. Propranolol is going to be the most common one that's used. And just remember the beta blocker is that LOL. Atropine is another medication that can be used to treat asystole, bradycardia, or pulseless electrical activity of less than 60, with a heart rate less than 60. And then adenosine can also be used to treat paroxysmal supraventricular tachycardia. What we're All of the slides for the most part for until I get to the end of this little section are going to be referring to beta blockers unless I say anything specifically. Okay? It can. Indications are different and routes are different. So atropine, they make like eye drops. You can put it in their mouth to dry up secretions. It affects anticholinergic, so it is stopping acetylcholine, which is what is affecting that. For that same purpose is how it is affecting the arrhythmia, but the route is different and dose is going to be different. Um, okay, so the beta blockers are going to block the beta receptors. If we don't go over that, I'll tell y'all, I'm at least going to go put a picture, if I haven't already, of where beta and alpha receptors are in your body so that y'all can see that if it is specific. I think when we go over angina, I have these spelled out more specifically, but it shows where the different medications are. It can be like specific targeted to certain receptors, or they can just be non-selective. It can just be in general. And so, based on what type it is, it's going to affect those different receptor sites. Some of those receptors, beta 2 receptors, are on your lungs. And so if it's non-selective, beta 1 receptors are on your heart. So if I'm affecting the heart and the lungs, if somebody has asthma or something like that, then I potentially, if I give them this medication and it can affect their lungs, which allows them to not have broncho dilation, then I can potentially worsen their asthma. Okay, so understanding where those are acting will make a difference in contraindications and what side effects that you may see. So I'll put a picture up that shows where those receptor sites are and where those drugs specifically are affecting. But in general, when you hear beta blockers, they're working in the same way. Okay. So they're going to decrease the heart rate, reduce the cardiac output, lower the blood pressure, and decrease renin, which are going to further reduce the blood pressure. Okay. These are given for rapid AFib, aflutter, and paroxysmal supraventricular tachycardia. Also can be used to treat hypertension, angina, premature ventricular contractions, and only one of these, not beta blockers, treat VTAC. Trying to see if there's anything else. So then I do have a note here that adenosine is the drug of choice for SVT if vagal maneuvers aren't effective. Vagal maneuvers, like asking somebody to cough or bear down. Okay, so for these, I do have notes about the different preparation for these. I don't really think y'all need to know that. Adenosine is given IV push, and they must be on continuous cardiac monitoring for that. Digoxin also falls in this category. It can be given IV or orally. And then I think that's really all I wanted to say about that. The class 2 are contraindicated in severe bradycardia. So beta blockers, I said beta blockers, and what other drug we have to measure apical heart rate? Very good, digoxin. AV block, cardiogenic shock, respiratory depression. Because we're slowing it down, and we're decreasing the output. Okay, so considerations. We haven't really talked about this either. So I do have the asthma COPD. There is a risk for bronchospasm because of the impact on the lungs. The other thing for hyperthyroid, y'all think back to patho. What does hyperthyroid look like? Yes, that's right. And I'm hyper, right? Because it's my metabolism. So I'm up. So if I had thyroid issues and I was monitoring for hyperthyroidism, what would I expect to see? When my thyroid is elevated, what would I think? What might trigger me that it's elevated? A high heart rate and a high blood pressure. So if I'm giving somebody something that's decreasing their heart rate and blood pressure, they wouldn't see that, right? Same thing with hypoglycemia. The signs that their blood sugar is low would be their heart is racing, right? They might feel anxious, their heart might be racing. If I'm giving them beta blockers, they may not get that sensation. And so they wouldn't know their blood sugar is low. So it would be very important for them to monitor their blood sugar. Okay? Pregnancy and lactation, we need to make sure the benefit outweighs the risk. They may need decreased doses if they have renal or hepatic dysfunction. Could have dizziness, fatigue, hypotension, bradycardia, AV block, other arrhythmias. Could have issues with perfusion, bronchospasms, decreased libido, exercise intolerance, shortness of breath, flushing, and headache are specific to adenosine. Okay, these can have interactions with calcium channel blockers, anti-diabetic medications, or methylxanthines like theophylline and caffeine. So those can block adenosine receptors and make it not work the way that it is supposed to. And then this makes sense. If a beta blocker is going to slow the heart rate and lower the blood pressure, if I'm giving this with another medication that does that, it's just going to make it worse. Okay. So our prototype here is propranolol. It is non-selective, so it blocks the beta 1 and 2 receptors. It can be indicated for arrhythmias, hypertension, angina, migraine. Another interesting fact about propranolol, because it stops that fight or flight, because that's the way that it works. If you have like stage fright, or if you are in a situation where you're about to get really nervous, you anticipate that this can happen, sometimes they'll prescribe propranolol to calm you down so that you don't have that. So it's not an anxiety med, it's not treating that, but it stops that sympathetic response, which I think is interesting. Hmm. Hmm. It just lowers that anxious response. It stops that fight or flight response, which is it is interesting that that is a medication for that. I think I was teaching when I knew that. And that was interesting to me also, of like, that, why are you giving somebody blood pressure? Like, that's what I had always given beta blockers for. So I'm like, why are we giving blood pressure medicine to somebody who's anxious? But that is interesting. And probably the better indication for that would be like, if it's not if it's not something you experience every day, like, this isn't a anxiety problem, this isn't a prolonged problem, this is a I'm about to go do this and I anticipate it type problem. And then, so when I'm giving somebody propranolol, what would I want to know before I go give it? Blood pressure, heart rate. If I'm giving it for an arrhythmia, I want to know what their heart rhythm is. And then I'm also monitoring that after. When would I hold it? When wouldn't I give it to them? Very good. And we're checking their apical pulse, right? Trying to see if there's anything else. So tell me about this. This isn't specific to arrhythmias, but since we're here and we're talking about it, I have already said this and I hope that y'all remember, but if you don't, we're going to talk about it. So this tells me that propranolol, which is a beta blocker, I want to monitor for signs of heart failure. Okay, and probably on here it says don't give to people who have heart failure. If it didn't, it probably said that on another slide. Think back, long time ago, 30 minutes ago, when we talked about heart failure. What did I say is first line treatment for heart failure? Which includes which medications? Beta blockers. So why on earth are you saying they're contraindicated, or to monitor for the side effects of that? What is this going to do? How's it helping? Slowing it down. It's lowering the workload, right? So that would be good for first line treatment. I don't want it to overwork. If I slow it down, it ain't gonna be able to do it, right? So there is a distinction. It is a distinction between first line for heart failure. Yes, I want to give them beta blockers. I don't want them to have to work so hard. But after it's wore out, if I give them beta blockers, they're not going to be able to compensate. It's going to be too much. It's going to be overloaded. It's not going to work. Okay. So the I want you to just recognize that of if somebody has a heart rhythm and an altered heart rhythm, and I'm slowing down their heart, that heart failure, depending on what they have going on, could be a side effect of that. Okay, so we're just monitoring for signs of that, but that can be confusing. If I just told you to go give them some beta blockers if they have heart failure, and then a contraindication that you read on this is don't give to people with heart failure. So just assessment, knowing your patient and knowing the level or severity of their heart failure makes that decision. Okay, but we're on, what are we talking about? Rhythms right this second. Okay, so lowering heart rate, lowering blood pressure. Also, what are two other conditions that I would be worried about giving somebody a beta blocker to? Bradycardia? Hmm? Say it again, babe. That's right, bradycardia. What else? What did I say it could mess up? There, did you say glucose? Hey, diabetics, yes, why? They might not. I love attempts. I mean that from the bottom of my heart. We are allowed to be wrong in here, me included. You were there. I know it. And you very well could have said what I'm wanting you to say. Um, the it masked hypoglycemia, right? So they might not be able to recognize that. Who else? Hyperthyroid, right? And actually hypo and hyper. So if somebody has thyroid issues and somebody has diabetes, then that could be a concern. There's one more that I forgot. That's right. So if somebody has asthma, if somebody has COPD, it could potentially stop or increase bronchospasms, which would not be good. Okay. Um, all right, moving on. Class 3. So these are potassium channel blockers. Amiodarone and dronedarone fall into this class. These are indicated for life-threatening dysrhythmias, VTAC, VFib, or atrial dysrhythmias like AFib or AFlutter when other medications haven't been effective. Um, so all of these medications do have the potential to cause arrhythmias. Amiodarone specifically can have fatal toxic reactions, but it is the drug of choice for VFib or pulseless VTAC in cardiac arrest. Um, Trying to see if there's anything else. Most of the time when I've given this to patients, um, people who have AFib or AFlutter, a lot of times this is the medication that they are on. And here are some other drugs here that fall into this category. Okay. So for patients with amiodarone, we want to monitor renal function, electrolytes, and EKG. They do have a potential to develop an arrhythmia from taking these. Dronedarone is contraindicated in people who have permanent AFib, decompensated heart failure, or AV blocks unless they have a pacemaker. What that first note, what I want to say about that is if somebody is in a life-threatening arrhythmia and the only choice that I have is to try giving them amiodarone and see if it works, there's no contraindication, right? So if the other choice is they die, or I try giving them this medication, there that would be the indication. Okay. Um, all of these also can worsen shock, hypotension, respiratory depression, and renal or liver disease. Amiodarone has a potential for lung toxicity and liver toxicity, and can be given PO or IV. For amiodarone specifically, I don't want to say this wrong, but I'm 95% sure it can cause iodine deposits, which is a complication or would be contraindicated in patients who have thyroid issues. Okay. And then because of those deposits, that can happen in lung tissue, and so that would also be contraindicated. Um, we want to use caution with all those things that I just said. Um, and then common adverse effects: nausea, vomiting, weakness, dizziness, hypotension. If I'm given medications that can also cause that, obviously that's going to be worse. They can develop bradycardia or a V block that could lead to heart failure. They also can get a prolonged QT interval, which puts them at risk for torsades de pointe, which is a deadly ventricular arrhythmia, very, very fast. And so we are monitoring QT intervals specifically with Sodalol or Defitelide. I've never even heard of that medication. Okay. So other drugs that they may interact with, digoxin and quinidine, they there's a risk for toxicity. Other things that affect their QT interval, like antihistamines, phenothiazines, tricyclic antidepressants. We need to make sure we're monitoring electrolyte levels, EKG, and concurrent use of other medications that can affect their rhythm. If these are taken with beta blockers, verapamil, or diltiazem, there's an increased risk for heart block or bradycardia. And yeah. Okay. Amiodarone is our prototype drug. It has been associated with potentially fatal liver toxicity. They also can get ocular abnormalities as well as a blue or gray skin discoloration that would be considered toxicity. The ocular, they get those little deposits in their eyes, which can lead to blindness. They can also have lung fibrosis, phototoxicity, and other arrhythmias. So here is a little card on amiodarone. Trying to see if there's anything else that I want to tell y'all about that. So as far as monitoring my patient, if I'm assessing my patient who's taken amiodarone, what do I want to look for? Okay, what's that gonna look like? Okay. Okay. If they're having any vision issues, right? Arrhythmias would be very important. How is their heart rhythm? Because first of all, I want to know if it's working. Let's start there, right? What else? Their lungs, right? How are their lungs functioning? Do they have a cough? Do they have any trouble breathing? Are they having any chest pain? I'm monitoring their heart rate. And then vision will be important, looking at their skin, as well as nausea, vomiting, or any signs of hypo or hyperthyroidism. And then liver, we've said what we know what to look for if somebody's having liver issues. Okay, the class 4. These are calcium channel blockers. I'm not getting deep off in this because we already talked about it, okay? So diltiazem and verapamil have that more direct negative inotropic effect that decrease the force of contraction, and then they also have a chronotropic effect, negative chronotropic effect, which means they are lowering the heart rate. These should not be used in patients who have heart failure, and because their heart already isn't functioning the way that it's supposed to, so I don't need to slow it down or make that work. So this is work less. So these are used for rapid supraventricular arrhythmias, aflutter or paroxysmal SVT, and can also be used as antihypertensives and anti-anginals. Can be given IV or PO. Make sure we're not giving these to pregnant people. Don't use it in severe heart failure or hypotension. Side effects of these, they're going to have a lower heart rate. They're going to have hypotension, reflex tachycardia, edema, and dizziness. So remember that if they develop edema, what am I going to tell them? What do we think? These are all great guesses. What do you think? I'm sending you home with your calcium channel blocker. You might notice some swelling. Stop taking it. Elevate. What'd you say? Uh-huh. Weigh themselves. Okay. What else? Are we worried about it? Yes, I'm worried about it. So if they experience this, they need to let us know, right? I don't want them to self-treat. I don't want them to have developed heart failure and then we're making it worse, right? And so I want them to let me know this. We might be fine with it. We might tell them to elevate it. We might tell them to decrease their fluid intake. We might just tell them this is something that happens, but I need to know first. I need to know if that's heart failure or not. Dizziness is another side effect. I think that's it on that. All the other drugs that are affecting their heart rate or rhythm could potentially cause worse issues. The I don't think that I said this. If these are given IV, within 48 hours of an IV beta blocker, there can be severe cardiovascular issues. Okay, so very important not to give those within 48 hours of each other. They can have interactions with cyclosporin, other antihypertensives, other things that reduce the heart rate, and other things that reduce contractility. Our prototype is diltiazem. This is on page 804 and 805. Which of the following is an adverse effect of class 2 antiarrhythmics? Very good. Bronchospasm, because what's class 2? Beta blockers. Very good. All right, and then these I just added. This might be helpful to you of just what is in each class and what are some of the side effects that can occur from those. I'm not reading over this. That just might be helpful. And then I found this little thing, and I do think that this is helpful for you to know. It just goes over maybe if these are easily confused for one another, amiodarone and adenosine, of indications for when those might be given. One of the things about adenosine that I think is very important for you to know is they'll give that to treat paroxysmal SVT. When they give that, the patient can flatline. Um, and it's temporary, but you would need to know that, and I need them to be on cardiac monitoring, okay? Um, so first we would try to have them vagal down, which like I said is holding your breath, cough, bear down, whatever. And if that didn't work, then they can give them adenosine. Those are some helpful little hints of adenosine is on the scene to stop SVT, of how to remember that. And then when you would hold this, here's a little hint that for when you would hold adenosine, bronchoconstriction, asthma, dopamine, sick sinus, theophylline, and then for AFib or AFib or second to third degree blocks, make sure your patient's on a monitor. The side effects of these: flushing, impending doom, nausea, dizziness, or a metallic taste. And then amiodarone, indications for those are those more serious or harder to treat arrhythmias. The I think those are just helpful things up there for you to recognize how those are given or indications for them. So it's going to slow it down and just when you're holding amiodarone and what potentially could happen as a result of it. Okay. Now, whether that's helpful to you or not, I don't know, but I did think that that did a good job of summing up the differences between those and indications. Okay.